The lecture we're going to talk about now are the neonatal surgical problems, which are very important because in neonatal surgical problems we face them sometimes and we need to consult a surgeon, but sometimes we need to perform or let's say manage these cases properly until the surgical role starts. First of all, when to diagnose a surgical problem. There are some symptoms that can suggest that there is a surgical problem. I'll start with the first two main presenting symptoms that are common in our NICU. The lesions that cause respiratory distress and lesions causing intestinal obstruction. We need to know what are the causes of respiratory distress that may be surgical, because respiratory distress is the most common presenting symptom in most of our neonatal ICUs. Lesions causing respiratory distress include esophageal atresia, whether with a fistula or without a fistula, and we will talk about this in detail. Diaphragmatic hernia, congenital lobar emphysema, cystic pulmonary airway malformation, and this is sometimes mixed up with cases of diaphragmatic hernia, choanal atresia, and this is when we diagnose it, it's very easy to do an immediate management in it until the definitive treatment is done, so we must suspect it. Pierre-Robin syndrome, tracheal agenesis, laryngotracheal clefts, laryngeal webs, vascular rings, all these, if they are present, the neonate may present with respiratory distress of a variable degree. Let's start by talking about esophageal atresia, whether it's associated with a fistula or not, and we will explain this in the types of esophageal atresia. We need to know that at least 85% of cases of esophageal atresia will have an associated fistula. When I say esophageal atresia, this means atresia of the esophagus. In at least 85% of these cases, there will be an associated fistula between the esophagus and the trachea. Often the baby is low birth weight, whether preterm or small for gestational age. And once we have a case of esophageal atresia, we must consider other anomalies. There is a vectoral association, and this is very well known, and we must search for these anomalies of the vectoral association. What are these defects? We need to see vertebral defects. We need to suspect an imperforate anus. We need to check for cardiac defects. We need to check for renal problems, whether renal dysplasia or other defects. And we need to check for limb anomalies, because these are the common associations associated with a tracheoesophageal fistula. There is also an esophageal atresia with a proximal fistula, and this is around 1% of the cases. This means that there's an atretic esophagus with a fistula connecting the proximal segment of the esophagus with the trachea, and the distal segment has no connection to the respiratory tract. Finally, there is an esophageal atresia with both a proximal and a distal fistula, and this is in 1% of the cases, and that's why surgeons sometimes need to search if there is another fistula so that they don't miss closing one of the fistula. And luckily, this is only 1% of the cases. We can suspect a case of esophageal atresia or esophageal atresia with a proximal fistula when there is no gastric air bubble. In postnatal presentation, the most common is there will be excessive frothy salivation at the mouth of the baby and maybe vomiting. There will be respiratory distress in most of the cases. And in absence of a fistula, when it's a pure esophageal atresia, as we said, there will be no gastrointestinal gas and a scaphoid abdomen. Edge fistula is usually rare, and it usually presents after the neonatal period with repeated choking and repeated cough and recurrent chest infection. But it's not very common to present in the neonatal period, although there are some cases we've seen, but it's not common. Diagnosis: the first thing we suspect when there is inability to pass a catheter from the mouth or nose. you enter a nasogastric catheter, and then you cannot enter it nasogastric nor orogastric. We do an immediate X-ray which shows coiling of the catheter. The H fistula is diagnosed by a water-soluble contrast during sign fluoroscopy, and definitive examination is by combined bronchoscopy with passage of a fine balloon catheter from the trachea to the esophagus. So this is usually how we will diagnose an esophageal. Our management will include the pre-operative management. This is a surgical case, but we have a very important role to play pre-operatively because we need to take care of the baby as neonatologist until he enters the surgery. We have two main targets: to minimize the risk of aspiration, therefore avoiding a chest infection, and to avoid gaseous distension of the GIT. Where will this gaseous distension come from? From the air passing through the fistula into the GIT. And we have a problem in this situation because in these cases we cannot do nasogastric decompression as in other cases of intestinal obstruction, where we do a nasogastric decompression to relieve any distension. But in these cases we cannot. Why? Because we have an esophageal atresia, so we cannot reach the GIT to do a decompression. How do we perform? The first thing we need to do is a multiple end-hole suction catheter. It's introduced in the proximal pouch with continuous suction. This will help remove the accumulated secretion. The head of the mattress is elevated 30 degrees. This decreases the risk of reflux of the gastric contents into the fistula and the aspiration of accumulated oral secretions. We need to try, if possible, to avoid mechanical ventilation, but I need to say if possible, because in many cases we may need to ventilate. We just want to avoid the ventilation until the fistula is controlled. Why do you think we need to do that? Because once we ventilate, this positive pressure that we're introducing, it will pass into the respiratory tract, and part of it will produce more introduction of air through the fistula into the GIT. So I will have a gaseous distension in the GIT that I cannot control. So this will be more with mechanical ventilation. If intubation is required, then this case has become a surgical emergency. Of course, esophageal atresia is a surgical emergency, but now it's become emergent that it needs to be operated upon very fast. The endotracheal tube should be introduced a bit lower than usual, just above the carina, but we need to take care to avoid accidental intubation of the fistula. If mechanical ventilation is required, we need to use high rate, low pressure. A high rate with low pressure. And we need to avoid heavy sedation in these babies. Why do you think do I need to avoid this heavy sedation in these babies? Because it compromises the patient's spontaneous respiratory effort. Okay. The treatment, as we said, is surgical, either by an immediate gastrostomy tube or a primary anastomosis of the proximal and distal ends of the esophagus with closure of the fistula. When they find that the two ends of the esophagus are very distant from each other, they sometimes need to do a gastrostomy, and primary anastomosis is not a choice. Mechanical ventilation and nutritional management in these cases are very challenging, and these cases must be really be taken care of, and we do see a lot of cases in our NICUs. Let's go on to the second surgical problem we need to discuss that causes respiratory distress in our neonates: diaphragmatic hernia. And most commonly, it's found in the left hemithorax. This is the most common, but it can be found on the other side, very rare to be bilateral. 50% of the cases are associated with other anomalies, whether cardiac, neural tube, intestinal, skeletal, renal, all have been reported, and it has been reported to occur with trisomies 13 and 18. and it has been reported to occur with some syndromes such as Beckwith-Weidman syndrome, Pierre-Robin syndrome, and other syndromes. These have been reported to be associated with them a diaphragmatic hernia. Prenatal diagnosis usually occurs after 16 weeks gestation, and that's why sometimes it is missed, because sometimes they do not do a sonar after 16 weeks gestation, so sometimes it's missed. But when the mother has a polyhydramnios, this should actually prompt a later fetal sonar, and this may help in the diagnosis. The advantage of this prenatal diagnosis is that this can help me prepare that this woman must deliver in a tertiary care center so that the baby is well taken care of. And it will help in my immediate neonatal resuscitation and management. The baby presents usually at birth with cyanosis, respiratory distress, a scaphoid abdomen, because actually the abdominal contents, part of them are in the chest, decreased breath sounds or absent completely on the side of the hernia, with heart sounds displaced to the other side. Presence of the liver in the thorax correlates usually with a poor prognosis. We do have other predictive parameters that we look for in these babies. There's something called percent predictive lung volume, and this is measured by MRI. This percent predictive lung volume measures the relative lung volumes, and it has been found that the lower the percent predictive lung volume, the higher the risk. Also, the lung to head ratio is also measured prenatally, and it can really help predict the severity of the involvement. In many sense, the more the lung to head ratio, the better the survival rate. In some centers, they have reported that a lung to head ratio of more than 1.4 may have a 100% survival rate. So in some centers that do this ratio, they have seen how this can help them predict the prognosis for the baby they're dealing with. Treatment of diaphragmatic hernia is surgical, but we do have a pre-operative role. If the severe case is prenatally diagnosed, they may be managed by immediate exit procedure and immediate ECMO. All neonates in the normal delivery, all neonates must be intubated immediately, and bag and mask ventilation is completely contraindicated. And I think this is understood why, because when we do bag and mask ventilation, some of the air will pass into the airway and some of it will pass into the GIT. So we are going to perform more gastrointestinal distension. And the problem is that this GIT is partly in the chest, so it will do more of a lung compromise in the chest. We need to avoid hypoxia and acidosis in these patients. We need a nasogastric tube insertion attached to continuous suction so that there is no distension that occurs in the GIT, so as to relieve the chest from further compromise. Heavy sedation also should be avoided. And our target is to avoid barotrauma and minimize the pulmonary hypertension, because these patients, their main problem is that they have an associated pulmonary hypoplasia. And this associated pulmonary hypoplasia is associated, of course, with pulmonary hypertension. And this is the primary cause of death. So the mortality is actually related to the pulmonary hypoplasia and hypertension. And that's why the exact optimum time for surgical intervention in these patients is not known. The patient, number one, must be stabilized. To get a better prognosis, the patient must be completely stabilized before entering the surgery. And sometimes the stabilization is a bit difficult. The surgical repair may be done either through the abdomen or the chest, and they reduce the intestine into the abdominal cavity. As we said, I'll just revise this with you again. We have a better prognosis if herniation of the bowel into the chest occurs after the second trimester. Maybe this point I hadn't said it, but we have a better prognosis if the herniation of the bowel into the chest occurs after second trimester. We mentioned before, absence of liver herniation has a better prognosis. Absence of coexisting anomalies, especially the cardiac, this gives me a better prognosis also. An early oxygen tension and carbon dioxide tension can help me also predict the prognosis of the patient. So this is how we can predict partly how the case is going to go. We'll go on to the big topic of neonatal intestinal obstruction. Neonatal intestinal obstruction is an intestinal obstruction occurring during the first month of life. We have a very simple classification I wanted to refer to. We can divide this intestinal obstruction into mechanical or functional. Mechanical obstruction can be divided into congenital or acquired. Congenital cases may be intrinsic or extrinsic factors, and acquired mechanical obstruction, such as malrotation, strictures, incarcerated inguinal hernia. These are all acquired mechanical obstructions. There is the functional obstruction, such as an immature bowel motility in the preterms, or Hirschsprung disease, because this is a functional problem, or paralytic ileus, and we see these cases in our neonatal ICUs. There is another classification for the intestinal obstruction we're going to enter into now, according to the anatomy. If we classify according to the gastrointestinal tract, first of all, it may be an esophageal cause as esophageal atresia, tracheoesophageal fistula, whether TEF or TOF. Gastric cause as congenital hypertrophic pyloric stenosis. It may lead to intestinal obstruction. Duodenal, and this is very common. Duodenal, whether atresia, whether stenosis, whether a diaphragm in the duodenum, whether malrotation with bands or volvulus, whether an annular pancreas. These are all causes for duodenal causes of neonatal intestinal obstruction. We may have jejunal and ileal obstruction, such as an obstructed inguinal hernia, intussusception, not very common in our neonates, atresia, stenosis, meconium ileus, peritoneal bands or hernia, or duplication cysts, and these are less common causes. Large bowel obstruction, and we see a lot of these. Number one, Hirschsprung disease, which is a functional obstruction, as we said. Anorectal anomalies, such as, most common, all of us know, the imperforate anus. Imperforate anus should be diagnosed commonly in the delivery room after the resuscitation and so on, while we're just doing a routine neonatal examination. Meconium plug syndrome, or atresia, and this is the least common. We also have necrotizing enterocolitis. This may be a cause of neonatal intestinal obstruction. And we may have a complicated inguinal hernia. And maybe we put this in red just to alert the neonatologist, because it's very common that it's missed. How is it missed? The neonate comes presenting with an abdominal distension and vomiting, and very typical picture of neonatal intestinal obstruction. We send for X-ray and we do everything, and we didn't even expose the genitalia. If we expose the genitalia, this will save us a lot, because we will see the hernia and we will find it is a complicated inguinal hernia. So it must be excluded, because the diagnosis will be very easy and you will save the baby, instead of if the delay in the diagnosis may lead to a gangrenous loop of the intestine and excision of part of the intestine that may be unnecessary, because early diagnosis will save us from this. General principles for neonatal intestinal obstruction. Let's just say a very clear sentence. Any baby presenting with persistent bile-stained vomiting should be considered a surgical emergency until proven otherwise. And we must learn also how to manage this or how to diagnose these cases. The cardinal signs are colics, constipation, vomiting, visible peristalsis, distension, or dehydration. Let's start by the stomach problem, congenital hypertrophic pyloric stenosis. Any neonate presenting with projectile, non-bilious vomiting associated with hunger and constipation should be considered as congenital hypertrophic pyloric stenosis. So we must take care of the word projectile, and we take care of the associated hunger that is in this baby. Actually, when you see a baby with congenital hypertrophic pyloric stenosis, you feel it in his eyes that he's very hungry and he's very irritable and alert. Etiology is unknown, but it appears to be polygenic, environmental, and genetic. The pathology we have that causes this problem is that there is progressive hypertrophy of circular pyloric muscles. This leads to persistent vomiting in the baby, causing development of hypochloremic, hyponatremic alkalosis and dehydration. And this electrolyte imbalance must be managed. And this is the most important role for the neonatologist in these cases, to manage this electrolyte and acid-base disturbance. So this vomiting, it will cause a hypochloremic, hyponatremic alkalosis and dehydration. Symptoms, as we said, projectile, progressive, non-bilious vomiting, after which the baby is hungry and ready immediately to suckle again. So you don't feel he's sick because he vomits, and he wants to feed immediately again because he's hungry. Classically, usually the symptoms start second to third week after birth. Not common to start in the first week of life. The signs of dehydration may be very severe and life-threatening, and you may see, on exposing the abdomen, a visible peristalsis can be seen in the upper abdomen after the baby is given a test feed followed by projectile vomiting. You may see a visible peristalsis. So this is an X-ray showing the severe gastric dilatation, and this is an ultrasonographic view. The ultrasonography, the doctor performing the ultrasonography measures the length and the width of the pyloric canal and gives us a report of it to see if we have a pyloric stenosis or no. Differential diagnosis of these cases, first of all, gastroenteritis, because sometimes it's misleading. The mother says vomiting, and he may be oozing a slight fluid or something. She thinks it's diarrhea, but these patients mainly present with constipation. We need to exclude reflux as a cause of vomiting, and actually I need to say also one of the most common causes of vomiting is excessive feeding. Any other obstructive lesion of the gut, or increased intracranial tension, which is not really common. We need to do the imaging sonography and a contrast X-ray, and it's very important to do electrolyte, serum electrolytes, and blood gases, because as we mentioned, we do have an acid-base disturbance and an electrolyte disturbance, and they need to be corrected prior to surgery. So the main treatment for us, first aid treatment, is correct your dehydration and metabolic disturbances. This is pre-surgical, pre-operative management, and it's extremely important in these patients because we see very high pHs, 7.5, and very high levels, and they need to be corrected before entering surgery. The definitive surgery, they do a Ramstedt pyloromyotomy, and the prognosis is very good in these cases. Let's go on to duodenal obstruction. A duodenal obstruction, let's say there may be stenosis, there may be atresia. There are three types of atresia. Type 1, that they call the web. It's a mucosal diaphragmatic membrane present in the duodenum. It's just a membrane. Type 2, there are two atretic ends and they are connected by a short fibrous cord. Type 3, there are two atretic ends with complete separation of the two ends. Commonly it occurs with Down syndrome, and this is very common that we find a neonate presenting with Down syndrome and coming with bilious vomiting, diagnosed as duodenal atresia. The bilious vomiting is common to occur a few hours after birth. When we do an X-ray, very common, there is the typical characteristic double bubble sign in the X-ray. The preoperative management that concerns us mainly is that if the patient is dehydrated, we need to do fluid and electrolyte balance very well adjusted, and we need to do a decompression by the nasogastric tube. We introduce a nasogastric tube and we keep it open so that it relieves all the fluid and the bilious secretions so that we don't have any abdominal distension. The treatment is by duodenostomy with a very high success rate. The prognosis is very good. There is a pathology called annular pancreas, and this may lead to a form of duodenal obstruction that may be mixed up with duodenal atresia. A small hint, sometimes cases of duodenal obstruction are not they are diagnosed only as duodenal obstruction. Actually, it's a case of malrotation, and this is very important because, as we'll say later on, malrotation is a serious problem. So we need to take care of that. Since we'll not get into the discussion of ileal atresias and jejunal atresia, the prognosis in duodenal atresia is better than in ileal and jejunal atresias. The presentations are very common to be alike. The jejunal and duodenal atresia and ileal atresia also present with bilious vomiting. How about meconium ileus? Meconium ileus, this is when we have an obstruction of the ileum due to thick inspissated meconium. And the meconium ileus is a very frequent cause of meconium peritonitis, because when there's obstruction due to the thick inspissated meconium, the intestine may just perforate and meconium will leak in the peritoneum, and this leads to peritonitis. 90% of these patients with meconium ileus will have cystic fibrosis, so they need to be investigated for cystic fibrosis even later on. But we need to keep this in mind, not just manage the case and discharge the patient without even referring him for diagnosis of cystic fibrosis, so that we don't miss this patient. The plain X-ray gives a ground glass appearance, not the typical air fluid levels, but the ground glass appearance due to the meconium. If we do a gastrographin enema, it's both actually diagnostic and has a potential therapeutic effect, because it may actually mobilize this meconium and the obstruction may be relieved. In cases that fail from this gastrographin enema, operative intervention may be needed in the non-responsive cases. How about volvulus with or without malrotation? I hope you're still remember that we're under the topic of neonatal intestinal obstruction, and all these are under the title of intestinal obstruction. Malrotation, it may be associated with other anomalies as bowel atresias, and it's very important to know that bilious vomiting, this is very important, bilious vomiting equals malrotation until proven otherwise. Why? because intestinal viability is at risk. With a high cause of obstruction, there may be minimal abdominal distension. The distension occurs with lower obstructions. There may be signs of shock and sepsis, and the investigation of choice in these cases is upper GI series. The contrast, and we do a series, not just a simple film, no, an upper GI series. Starting to talk about Hirschsprung disease. Hirschsprung disease, most of us know it. We need to suspect it with failure to pass meconium in the first 24 to 48 hours after birth. This is very important because lately we've noticed in many NICUs, because maybe of the early discharge of the babies, there is no record of this. So we find the parents coming on the 3rd day of life and they tell us there's only small streaks sometimes of stool. When was the first time that he passed meconium? They don't know. Maybe this is because of the early discharge of the many cases now, but we need to tell the parents also to see, when we give the baby to the mother, if she's being discharged, let's say a vaginal delivery after 12 hours, we need to inform her that she needs to see when is the passage of the first meconium. And usually we don't like to discharge a baby before we make sure that he passed his first meconium. So it's very important to take a history when the passage of the first meconium occurred. The contrast enema may not show the transition zone, but the 24-hour follow-up X-ray will reveal the retained contrast material. The main diagnosis is by a rectal biopsy. This is the definitive diagnosis. We do a rectal biopsy. Constipation in these cases is relieved by gentle rectal irrigations with warm saline. And once the abdomen is decompressed by these frequent rectal irrigations and there is no more severe abdominal distension, we can start feeding very slowly, very gradually. Surgical treatment will depend. If the patient responds to these rectal irrigations and enemas well, then the surgeon may consider doing a primary pull-through procedure and save the baby from doing a colostomy. So what he does is we do this decompression, we start the oral feeding, and if the baby is responsive to regular washouts, as they call them, or rectal irrigations with the saline, then the baby goes on for a while and enters to do a primary pull-through procedure. However, if this decompression fails using these irrigations, or if the baby develops enterocolitis, usually in these cases a colostomy must be done, and then after a few months the definitive repair will be done later. We have a serious problem that we sometimes see, the omphalocele and the gastroschisis, or exomphalus and gastroschisis. These are actually errors of the midgut development and rotation. First of all, we'll talk about exomphalus major and minor and the gastroschisis. In both cases, we see a hernia, an intestine protruding, whether through the umbilicus. In these patients, we find the intestine protruding from the abdominal wall. There is an abdominal wall defect. The intestine is passing through an abdominal wall defect. If this defect is actually in the umbilicus, then this is in the umbilical cord. This is actually an exomphalus or omphalocele, and this is the major difference. In gastroschisis, the intestines pass through a defect to the side of the umbilical cord. So you find a cord and you find the intestine next to it. But in omphalocele or exomphalus, the intestine is actually in the umbilical sac. It's in the umbilical cord itself. And it's divided into major or minor according to the size of the umbilical defect. If the umbilical defect is less than 5 centimeters in size, this is called exomphalus minor. And if the umbilical defect is more than 5 centimeters, this is called exomphalus major. If the intestine, I'll repeat again, if the intestine is protruding through a defect not inside the umbilical cord, this is gastroschisis, and this is more serious. Exomphalus or omphalocele, as we said, the intestine is protruding in the umbilical defect. Amazingly, up to 80% will have associated anomalies all over the body. So we need to search in these patients for any associated anomaly because the percent is so high. Up to 80% will have anomalies. It's very important to know that the sac may be intact or it may be ruptured. So if I find the intestine visible, it may be actually an omphalocele, but the sac has ruptured, and we will see a photo of the omphalocele and a photo of the gastroschisis soon. The treatment in these cases is emergency, but I need to know what to do until the surgeon comes. I need to do a continuous nasogastric suction. Never attempt to return the contents in the abdomen. Do not attempt to do that. We just need to cover the sac with a bowel bag or saline-soaked gauze. And we stabilize the patient, mainly thermoregulation and fluid balance. I'll repeat again, thermoregulation and fluid balance. And then we do the surgical consultation. I will stop here and tell you that if the sac is ruptured, this is a very serious condition because the intestine will be exposed. So actually, the management will take these steps again, but it has become like a case of gastroschisis because the main difference between gastroschisis and omphalocele is that the omphalocele is covered by the cord, by the sac, while in gastroschisis, the intestine is next to the cord and it's exposed completely. In gastroschisis, we do not have the sac and the intestine is eviscerated. So this is a very serious problem. 12% of the cases, I will really stress on this, have other anomalies, but these anomalies are gastrointestinal. What do I mean by they will have other gastrointestinal anomalies? For example, atresia, whether duodenal atresia, jejunal atresia. So I need to search in these cases for other gastrointestinal anomalies, but usually this is not the problem at the time of diagnosis. In these cases, the first thing is to manage the gastroschisis. And these cases will need an immediate surgical management because the surgeons immediately try to attempt to reduce the intestine, if possible, into the abdominal cavity. They sometimes face problem is that the abdominal cavity is too small and they cannot replace the intestine fully, and they have their different surgical procedures to do this. So this is an immediate surgical management, but in these cases, actually, a prenatal diagnosis is very important because if we know, the surgical team actually attends in the delivery room with the neonatologist. So this is a very nice photo. It shows an omphalocele. As you can see, these three photos are photos of omphalocele or exomphalus. According to the size, we will divide them into exomphalus major and exomphalus minor. As you can see, the intestine is inside the umbilical cord sac. The whole picture below is very well obvious. It's an exomphalus major, as you can see very well. And if you take a good look, there's intestine in the lower part of the sac, and the liver is protruding in the upper part of the sac. This is a photo for gastroschisis. As you see, the intestine is protruding to the right side of the umbilical cord. It's eviscerated. It's not covered by a sac, and this needs immediate surgical intervention. And we never try to clean the intestine or do anything in it. This is a completely surgical emergency. And as we said, that's why a prenatal diagnosis helps us a lot. All we do is we either cover it with a gauze or better with, as you see, a polyethylene bag or intestinal content bag, just to avoid the, first of all, of course, avoid infection and exposure, and also to avoid the fluid loss that's happening while the intestine is exposed. So we just cover it until the surgical team arrives and starts to take care and starts to prepare for surgical management of this patient. Now we're going to just go very fast through presenting neonatal symptoms in surgical conditions. These are the minor symptoms that I wanted to mention. If you remember, we started our lecture with, we divided the surgical conditions we discussed into two: lesions presenting with respiratory distress, when we talked mainly about the esophageal atresia and the diaphragmatic hernia, and we talked about lesions presenting with intestinal obstruction, neonatal intestinal obstruction. Some of the small symptoms I wanted to mention that may alert you to certain surgical conditions. For example, when you see a scaphoid abdomen, you may need to think of two things: whether a diaphragmatic hernia or esophageal atresia without a tracheoesophageal fistula. When you see severe abdominal distension, you need to consider pneumoperitoneum or intestinal obstruction. We did not really discuss the pneumoperitoneum in our lecture, but just so that it's clear, the diagnosis of pneumoperitoneum, it's diagnosed by air under diaphragm. This is the main diagnosis, by a plain X-ray showing air under the diaphragm. As regards vomiting, we need to differentiate if it is bilious or non-bilious. The bilious vomiting, we need to consider intestinal obstruction, secondary to malrotation with or without volvulus. We need to consider duodenal atresia, jejunal atresia, ileal atresia. Non-bilious vomiting, we must exclude first the non-surgical causes, because these are very common and maybe even more than the surgical causes, such as excessive feeding. This is very common. Milk intolerance, decreased motility, and lesions above the ampulla of Vater as pyloric stenosis. Okay, our last slide I'd like to talk about is sometimes there are fetal symptoms or fetal signs, symptoms or signs that may denote the presence of a surgical condition. First of all, if the mother, during an ultrasonography, we find out that she has polyhydramnios, that is excessive amniotic fluid, then we need to suspect certain things. Most important, a gastrointestinal tract obstruction, including esophageal atresia, should be suspected. Abdominal wall defects that we just talked about, or diaphragmatic hernia. All these are associated with polyhydramnios. Another thing that is not very known between the neonatologists, but if by sonar antenatally we find intra-abdominal calcifications, this denotes actually intra-abdominal calcification. This denotes meconium peritonitis, and this usually occurs due to an antenatal perforation that occurred in the intestinal tract. So maybe we do not know this, or it's not very well known among us neonatologists, but we need to be alert about it, that if the sonar reports these calcifications, we should consider an antenatal perforation of the intestinal tract. I hope that the lecture was very clear for you. I hope that the surgical conditions I passed through may be clear. There are many, many other surgical conditions I didn't talk about. You need to read more. There are emergency surgical conditions and non-emergent surgical conditions. For example, we didn't really discuss a lot about the imperforate anus that will lead to intestinal obstruction. We didn't discuss a lot of things. There are other surgical conditions that you need to read about, such as cleft lip, cleft palate, which are not in emergency conditions, but you need to know a lot about. But I hope this lecture clarified some matters, and I hope it was clear enough for you. Thank you very much, and thank you for your listening. Thank you.